Let me ask you a question. Why do some patients with brain injury swell up silently while others spiral quickly into coma? And why does one CT scan scream stroke while another whispers hydrocephalus? The answer lies in understanding one critical concept: not all brain swelling is the same. Welcome to this breakdown on the 3 types of cerebral edema you must know. Think of this as your executive summary of a concept that underpins stroke management, neurosurgical emergencies, and neuroinflammatory syndromes. Let's dive in with a framework used by neurologists, intensivists, and radiologists alike, dividing cerebral edema into 3 distinct pathophysiological entities: 1. Transependymal, 2. Cytotoxic, and 3. Vasogenic. Each one has a different cause, a unique imaging signature, and specific clinical implications. First, transependymal edema. Imagine the brain's ventricles under siege, cerebrospinal fluid pressure rising due to an acute obstruction. The fluid, finding no outlet, begins to transudde through the ependymal lining into the adjacent white matter. So, this is transependymal edema, which is also called interstitial edema. Basically, it's the brain's version of a backflow problem. Now, the most common culprit? Well, it's usually acute obstructive hydrocephalus, like from a colloid cyst, intraventricular hemorrhage, or, mass effect. On imaging, you'll notice enlarged ventricles with T2 or flare hyperintensity radiating out into the periventricular white matter. You can think of it as a halo around the ventricles. But here's the diagnostic pearl. Don't confuse this with chronic small vessel disease in the elderly. So, how can you tell the difference? In chronic cases, you'll see cortical atrophy, widened sulci, and flattened gyri. The ventricles might be large, but the story here is really one of slow degeneration, not acute pressure buildup. Second, cytotoxic edema. This is the type you'll see in ischemic strokes. The pathophysiology is elegant and deadly. When blood flow drops, so does ATP. The sodium-potassium pump, the workhorse of neuronal homeostasis, fails. Sodium accumulates inside cells. And where sodium goes, water follows. This causes intracellular swelling, especially of neurons and glia. That's why this is called cytotoxic edema. On MRI, look for bright signals on DWI with restricted diffusion. Importantly, this edema respects vascular territories. It'll hug the boundaries of the middle cerebral artery or posterior circulation like a road map. This is the kind of edema where timing is everything. It appears early and it helps differentiate stroke from mimics. Third, vasogenic edema. Now we step into the realm of inflammation and barrier breakdown. In vasogenic edema, the integrity of the blood-brain barrier is compromised. Cytokines and inflammatory mediators loosen the tight junctions of capillary endothelial cells. This allows plasma, proteins, and even large molecules to leak into the extracellular space. What causes it? Think tumors, trauma, infections, multiple sclerosis, and hemorrhage. On imaging, it shows up as T2/flare hyperintensity, often with finger-like projections that follow white matter tracks. It does not respect vascular territories. Here's a pro tip. In broad strokes, you might see cytotoxic edema show up first and then vasogenic edema later on, especially if reperfusion or, hemorrhagic transformation happens. But for clarity in teaching and clinical reasoning, it's really important to keep the two distinct. Let's bring it all together. Transependymal edema comes from CSF overload and affects the paraventricular white matter. Cytotoxic edema results from energy failure, leading to intracellular swelling in vascular territories. Vasogenic edema happens when the blood-brain barrier is disrupted, so you get extracellular fluid along white matter tracks. This classification isn't just academic. It actually guides your diagnosis, your prognosis, and most importantly, your intervention. Know the difference, spot the pattern, treat accordingly. And next time you look at a brain MRI or CT, don't just see the swelling, read the story it's telling. Thanks for watching. If you found this breakdown useful, don't forget to subscribe for more high-yield clinical insights.